good number of people here, but hi, my name is Gino Farina. I'm a professor of emergency medicine and science education at Zucker School of Medicine and the assistant dean for the clinical preparation for residency. I was a former program director. My life has been these EPAs for the last many years, as long as they've been around. So go ahead, Judy.
Okay, and now you can see, I hope everyone sees the slides, correct?
Yes, we do. They're beautiful.
Okay, excellent. All right, so my name is Judy Brenner. I am the Associate Dean for Educational Data and Analytics at the Zucker School of Medicine. I have been here for 12 years, but this will be my last general club. As a faculty member, I'll be moving to a new institution starting in July. So I'm really very honored to be able to have this be one of the last activities here, because it's something that's been near and dear to my heart for a long, long time. I'm an internist as well, and just have been involved in medical education since the start of my career in 1994. So thank you, Alice, for letting Gino and I take this on.
Pleasure.
Shall we start, Alice?
Yes.
All right, so thank you for joining us. This is the report on core entrustable professional activities for entering residency. I'm sure a summary of a 10-school pilot. I'm sure that everybody's read the 69 or 79 pages of it. If you didn't, I don't know if you necessarily have to, because we're going to review it for you. But next slide. So I guess maybe to start off, we probably should just get a poll to see how familiar you guys are with the core EPAs. From not familiar to somewhat familiar to familiar and finally to very familiar.
And
I think we have a small group, so I don't know. What,
you could just call out, just give, what are your thoughts? What do you know something about EPAs, first time you're hearing about it? Thoughts?
So I know EPAs. This is Chris Sasri. We are starting to implement and in full force from July. We are implementing along with the EPA. We already have what's called the Simple app. So we're going to combine it in surgery, and I'm familiar with it.
Anybody else? Could I assume the silence means most people are not familiar with EPAs? Newbert, you're from family medicine. Could you unmute? Are you using EPAs in family medicine?
Yes, family medicine has been using them for the last couple of years. We're very familiar with them.
Okay.
Yes.
Thank you.
You're welcome.
Nubert, can I just ask, maybe you could share with the group a little bit of a description of how you're using them?
So basically, when it comes to time for evaluation, we give them out. So ACGME has some very well-defined EPAs for family medicine. So we just take the guideline from ACGME and give it to every faculty whenever they have to evaluate residents for medical knowledge, or let's say, for example, for patient care, there's some very specific EPAs under that, and we give it to the faculty and then they use it to evaluate the residents.
Yeah, well, so one of the things that when I was program director, the milestones came along, as we all know, milestones. First was, the core competencies, then there were milestones. And then I know for emergency medicine, and as like you said, in family medicine, EPA started to come around that encompass a lot of the milestones. So an EPA would have several milestones attached to it. So you knew if you can trust somebody to do that particular activity, that they met certain milestones. So it makes sense to use entrustable professional activities in the form of assessments. Right, I think we should go on.
Go ahead.
All right, so the goals for today are, we have 4 goals. The first one is to describe the 13 core entrustable professional activities for starting residency, to appreciate the gap between how a student self-perceives themselves and how a program perceives an early PGY1 resident in those core EPAs. Also to appreciate the gap between how a student self-perceives themselves and how an entrustment group from the medical school that they attended to feels that they're ready for those EPAs. And then finally, to describe those core EPAs that are easily accessible in medical school and the ones that are more challenging to assess. Next slide, please. So in 2014, the AANC published a list of 13 EPAs for entering residencies, and those are the core EPAs. And these are the things that residents were expected to perform with indirect supervision the first day of residency. Potentially, these can constitute a requirement from advancement from medical school to residency. To test the feasibility of being able to do this, the AANC convened a 10-school pilot project to see if these core EPAs could be taught and assessed in undergraduate medical education. And it ended up being a 7-year pilot project that ended in 2021. Next slide. So EPAs, there are a good number of definitions, as you probably know if you're working with EPAs, but this is probably one of the best ones. And EPAs are units of professional practice defined as tasks or responsibilities to be entrusted to the unsupervised execution by a trainee once he or she has attained sufficient competence. EPAs are independable, executable, observable, and measurable in their process outcome, and therefore suitable for entrustment decisions. So these entrustment decisions can be ad hoc, and this is somebody watching us or learner do something. So for instance, I would think, or we'd like to think, that if a learner walked into a room and the patient was diaphoretic and hypotensive and obvious respiratory distress, they would recognize that person as requiring urgent or emergent care and hopefully be able to initiate or at least escalate to a higher level to take care of the patient. So in that moment, you could say, sure, I trust this person to recognize that. But what if the person had subtle signs of a serious illness, maybe an unexplained tachycardia or something that wasn't as obvious that they were so sick, right? It'd be harder for you to say, would I trust this person to recognize those subtle signs of illness and be able to initiate treatment or escalate? Or would they just ignore it, right? So the ad hocs are okay individually and they're for that moment. And it depends on the urgency and depends on the particular situation, as opposed to the summative decisions, all right? These are the ones that are done over time. This is the ones that are done by different people at different time, and they're assessed and they're recorded, and there's a progress. So you know that this particular learner has seen many patients with many different presentations and was able to recognize on many occasions that people were sick and appropriately provided treatment as needed. So then that's a better entrustment decision. Okay, next slide. So these are the 13 core EPAs, which probably are very much different than the ones that are used in residency, right? And number 1, gather and perform a history. 2, differential diagnosis. 3, interpret tests and labs. 4, orders. 5, document a clinical encounter. 6, provide an oral presentation of the encounter. 7, evidence-based medicine. 8, patient handovers, right? Either give or receive a handover. 9, interprofessional teamwork. 10 is to recognize the patient requiring urgent or emergent care in the initial evaluation and management. 11, informed consent. 12, general procedures of a physician, which is really just phlebotomy, intravenous placement, and the BLS skills, so CPR, back valve mask, non-invasive airway management, initial airway management. And then finally, number 13, which is identify system failures, which is a big one and a very challenging one, as you shall see. Next slide. So EPAs are a form of competency-based education, right? And these are the components of competency-based medical education. You need an outcome, CEPA, right? That's forms the framework. Should be a progressive sequence of competencies to achieve that. Time is not the driver. It's not like you have to accomplish this in a preset time. Everybody does these at different levels, different times. So I can teach somebody how to place an IV, and somebody who has great manual dexterity will pick that up earlier than somebody who may need to work harder at it or longer at it before they can get to that. The teaching around these EPAs, similar to CBME, should be tailored toward those competencies. And there should be pragmatic assessments, right? So this is collecting multiple assessments continuously and following them and reassessing them or adding assessments as needed to allow for a high stakes decision to be made. Next slide, please. So what the AAMC did was they developed the 13 core EPAs, or they came up with the 13 core EPAs, and then they wanted to see how program directors felt that the graduates from medical school, how confident they were that the recent graduates were able to perform these EPAs without direct supervision. And they chose these 6 specialties: internal medicine, pediatrics, family medicine, general surgery, OBGYN, and psychiatry. Next slide, please. So this slide, we don't expect anybody to read much on this. I just shows you what the program director's perceptions were for each of the EPAs in their particular specialty. And what is meant to show you is that look at the huge variability or the wide variability within each EPAs and within programs. You can see in the lower EPAs, the patient safety 13 and the procedures 12 and informed consent, that those are lower in all the specialties, but there's still variability between family medicine and pediatrics and EPA 12 per se. And even in taking a history, EPA 1, there's a decent variability. Not everybody, actually nobody's at 100%. The only one, pediatrics, which is being the highest, but there's huge variability. Next slide, please. So this graph comes not from the report, but this graph comes from a supplement that was published after the report, based on the data from the report. And this is that data from the previous slide combined. So this is the overall program director's confidence for the EPAs. And again, we see here that there's a variability. That not one EPA is at 100%, and that some EPAs are much higher than others, and some are actually pretty low. So it's kind of hard to, okay, program directors who helped to develop the core EPA saying this is what we expect our interns to be able to do day one. But meanwhile, the medical schools, we're unable to prepare them to that level, obviously, because this is what they can do based on their perception. So obviously there's a huge gap, hence the pilot. Next slide, please. So to see if this is going to be something that's feasible, the AAMC convened 10 schools to participate in this pilot, to form curriculum, and assessment, and define a path to entrustment, and obviously required faculty development. And the primary goal was to use multiple schools to see the feasibility of implementing the core EPA's framework into the path of medical school graduation. The secondary goal was to narrow the gap between the actual performance expected upon entering residence, the actual performance versus that expected upon entering residencies. These are the 10 schools that were chosen. We actually put in to be one of the schools. We were not chosen, but these are the 10 schools that were chosen. As you can see, they're pretty much all over the country. There were 2 from New York, but they're pretty much all over the country. Some schools are bigger, some schools are smaller, some schools are in rural areas, and some schools are in big cities. Next slide, please. So this is rolled out in phases, and you can see here, we don't need to spend too much time in here other than to know that this is rolled out in phases. The first few years was clarification. Then it was, okay, let's develop toolkits in phase 2. How we're going to do this? Define the pre-entrustable descriptions and behaviors, right? It's before you get to entrustment, where are learners at and how can we define those to see where they're at and how we can get them to the next. And then starting in collecting data and assessing, and then the final thing is obviously, reporting and forming entrustment decisions. Next slide, please. So 6 schools started implementing with the class of 2015. 3 schools started in 2016. 1 school did not start until 2013, which was already phase 3. So schools varied in the number of EPAs implemented at each. All schools implemented at least 4 EPAs. Some schools chose to do all 13 EPAs. COVID hit, as we all know, around the time when this was supposed to come to near an end. So therefore, it was extended because of COVID, and some schools had to interrupt their process in developing these EPAs because of obviously patient care. Next slide, please. So there's a good number of highlights that came out of this pilot. Is that they developed a toolkit on how to assess the EPAs. They came up with the guiding principles, work-based place assessments, which they early on they realized how important these are. They also realized the importance of a longitudinal view of a learner's performance. And the importance of a coach. So the coach is somebody that's not assessing the student, but in helping the student or the learner interpret the data that they're getting back. This is what's coming back. This is where you're at. You need to get to this. How do we get you there? Right? And not involved in any component of the assessment at all. So it's a safe environment for the learner to develop. And obviously, you need a fair amount of faculty development in this. Next slide. These are the guiding principles to map educational opportunities and assessments, to measure the attributes of trustworthiness, particularly knowledge, skills, and attitudes, to create a longitudinal view of each learner's performance, and to form longitudinal relationships and formal coaching, to gather multimodal evidence from multiple assessors, all right, not just one, but many different ways to do it from different people, to include global professional judgments about entrustment. Formative feedback was key along the trajectory, right? So this is safe. This is not punitive. This is not summative. This is okay, formative. This is how we're going to get to the next. One thing that they formed was that the formal entrustment decisions were done by a trained group or a trained entrustment group. So this is a group that was created kind of similar to the clinical compassing committees that residencies use, that just look at the data. They're not involved with the student. They could be blinded to the name of the student. They just look at the data from all the assessments and say, yes, based on the number of assessments that this student did with this EPA, they are trusted, we can make an entrustment decision that they're trusted to perform this. The learner had to be an active participant in the entrustment process. That is key, knowing where I'm at and how am I going to get there, and how can I make myself get there. And then lastly, to align the formal entrustment decisions with nationally established performance expectations. Next slide. So for work-based assessment, they use 2 scales. I'm sure a good number of people are aware of the CHEN, or this is the CHEN modified scale. And this is a prospective supervisory scale, right? And you look on the right here, you could see, right? So you're only allowed to watch me do this, or okay, 2A, let's do this together. Or 2B, you know what, I'm going to be here, right? You do it and I'll step in if I need to. The other one is, I'm around if you need me and I'll come and double check. And then finally it's like, go ahead, do it. I'll check later, right? So that's 3B. So that's the CHEN scale. So some EPAs this scale fits perfectly. And then next slide, please.
Yeah.
For some EPAs, the retrospective coactive scale or the Ottawa scale is the better one. And this is, I had to do it, right? I had to walk them through it. I had to talk every once in a while, give them a little bit of direction. I just needed to be there just in case. And then I didn't need to be there at all, right? So those are the scales that they use for the work-based assessments. So now I'm going to turn it over to Dr. Brenner, who will talk to you about the outcomes and the data.
Okay, thank you so much, Gino. That was a great overview for the group. I do want to pause and ask the group. Wait, can you hear me?
Yeah, good idea. Pause for a minute. It was a
Yeah,
lot.
just if anyone has any questions, please feel free to put them in the chat. We'll definitely have time for questions and discussion afterwards. But any questions for Gino before we move on?
You know, the one thing I noticed, Gino, is that this is a serious task to do this EPA, you know, to say that you entrust somebody. Just the word entrustment is a big word that they've decided to attach to this. And, you know, I think in some ways, you know, our faculty are going to take it serious enough to give that entrustment where it really is entrustment, that they're with a real live patient doing the work that you hope. So I think when you look at the top EPA that's been sort of approved by schools in when you had the aggregate data of the history and physical, the output of that, even if the person didn't perform it exactly perfectly, would not be harmful to the patient. I mean, I guess physical could possibly, but basic physical head to toe. But when you think about procedural ones and different things, that's a little different, right? So when you're testing students.
No, so right. And this is why the group that does the entrustment does it only looking at data, looking what's available. They're not watching, so they're not biased as to like, oh, I like this person, I'm gonna, you know, they look like they could do it. No, the data shows that they're, so you have to demonstrate with enough data points that this person has done this procedure enough times that yes, I trust them to be able to do this on their own. So yeah, right, it's a huge thing. So now in this EPA, and as Judy will mention, they felt that they were not quite ready to make, they were only ready to make mock entrustment decisions, right? That these were not based for promotion or for graduation, that these were mocked only at this stage. I would imagine with time, we will get there. It's going to be challenging, particularly for some of the EPAs, but it would take time. But yes, you need a lot of data points and you need different assessors, and then you need an independent group to look at the data and say, yeah, based on the data, this person can do this on their own.
Elizabeth, so it looks like and yeah, I'm glad that Gino emphasized that about mock entrustment decisions. They, you know, you'll see that they put groups together to discuss the data, but nobody felt that there was enough, nobody felt that the data, and I'm kind of previewing some of the conclusions, but the pilot group did not believe that there was enough data to justify a high stakes decision. So nobody, you know, failed to advance or failed to graduate based on the data that was collected. So I'm going to say that up front, it's really important.
Yeah, that really is important.
And I think to speak to what you said, Alice, it's that they weren't able to do that despite an enormous amount of resources that went into this project. So I hope we're going to give you a flavor of the amount of work that went into the project, but they couldn't make those high stakes decisions despite, you know, a big commitment. Elizabeth, I see you have a question.
Yeah, thank you very much. And thank you very much for this important topic. So I wondered about the timing of introducing the EPAs into undergraduate medical education. Teaching how to recognize a differential might work from early on, but other EPAs might be really hard to enter. Can you comment on this a little bit more?
And well, I was going to say, why don't we hold that for the end
Okay.
as part of the discussion? I think it's a great question.
Thanks.
Great. Any other comments from people or questions? Okay. All right. This is when I really wish we were sitting around the table in person and we could talk about this, but let's move forward. So again, thank you, Gino. So what I'm going to do really for the second half of today is go through some of the data. Not all of it is data that you see in the 60+ page report that that we emailed out. There's so many other publications that came of this pilot group, but I borrowed mostly from one, and I'll reference it if anyone wants to read that article. It's a great one. But I did want to start by reminding people what Gino just said, that this was a long pilot. It actually did extend because of COVID, as he said. It extended. So you see the phases here, but I think the important part, without going into all the details, is that different schools were doing different things over this period of time. So it wasn't like they were in lockstep, all, starting with the same set of EPAs or anything. It was really the opposite. It was that some were implementing different EPAs, some were using different forms of assessment. The groups, these entrustment groups were a little bit different from school to school. But it was important at the end of the day to be able to collect data and aggregate data in such a way that we could draw some conclusions. And that's really what we're going to focus on today. So in the end, what I'm going to report to you is data that came from 7 groups, and the 7 schools of that pilot 10. And the reason for that is, among those 7 schools, those schools did 2 things. One is that they each implemented at least 4 EPAs. And the second piece is that they participated in all phases of the pilot. So it was because of that we said, okay, those 7 schools are the ones that we're going to look at. Okay. So in terms of the data, and this is really at the heart of what was collected and what we will look at to understand the conclusions that the report shared. So there's 2 main sources of data that we're going to look at. One is that came from the student side, and the other came from the school side. So from the student side, there are and there's more than this that was collected, but this is what we're going to use today to discuss the conclusions. So the first thing was the AAMC graduation questionnaire, which, if not everybody knows, this is a very important survey that is administered by the AAMC at the end of medical school. It actually starts around mid-February of the student's 4th year. And for the classes of 2019 and 20, the AAMC added questions about the core EPAs and a bunch of questions. Not only you'll see the answers to it, but they basically queried the students about these core EPAs. There was a second questionnaire that was also administered by the AAMC, and that came in the early PG1 year. So these students who were part of the pilot had to self-report activities related to the core EPAs. And, the big outcome that we were looking for here was under indirect supervision. So that's the ultimate outcome that we're looking for with the EPAs, is that you learn them in medical school, but by the time you get to residency, you can perform these functions with indirect supervision. The second set of data came from the schools. So the questions included the number of EPA-specific workplace-based assessments that were conducted, that were done. We, of course, looked at the outcomes of these groups that made determinations about entrustment. And schools also surveyed the program directors who now had these students to ask their perceptions of the students' ability to, and preparedness for residency. So this is what you're going to see, and this is what we'll walk through in the next couple of slides. Okay. One more slide before we get there, and that is, what framework did they use? So we always want to use a framework when we think about how are we going to evaluate anything. And in this case, this is a very accepted standard for evaluating assessments in general, but and some of these we already mentioned. So on the left here are the 4 areas: propriety, feasibility, utility, and accuracy. So the first thing, and I think Alice said this, is that they wanted to focus on the welfare of those affected. So the whole project was looked at through the lens of do no harm. And just to speak to why did the group never make high stakes decisions? It was because they did not want to do any harm to anyone without fully understanding this process. They also looked at feasibility, which we've heard that word come up before. So is it really possible to do this? And workplace-based assessment it's such a critical component of this whole system, because all these EPAs are dependent on collecting data, and that data has to come from observations in the workplace. So one thing that is very clear, and I hope Alice can back me up here, is that pre-pilot versus now, the term workplace-based assessment, came into being. It really evolved, it flourished. And I think we all understand that no matter what happens in the future, seeing students in and trainees in their environment and assessing them in that environment is what workplace-based assessment is all about. And I really think that, part of the value of this project was really making that idea come to life. So the utility, I said this before, that the ultimate ability of this project was judged in some ways on its ability to actually make these entrustment decisions under indirect supervision. And then there's the accuracy. So whenever we look at measures, we look at validity and reliability. So this was the lens that they used to look at the data that I'm about to present. Okay, so I have 2 slides I'm going to walk us through. And I borrowed these from Yoni Emil, who works at Columbia and was part of the pilot. So starting with the first column here, and I hope everyone can see my arrow, but we have the EPAs listed. And you'll notice quickly that the EPAs are not listed in order, and I'm going to come back to why that is the case. But here are your EPAs listed in shorthand. The second column is the number of workplace-based assessments per student. And again, this is data that came from the school. You see the source at the bottom. And what's important to notice here is, and the coloring helps us understand, is that there's a huge variation from H&P, for instance, or oral presentations, where there are 7 to 8 workplace-based assessments per student, down to the bottom here, where for procedures, very, very few. Even handoffs, 1. So the important thing for you to see, and you're going to see this in every column I present, there's variation. The second column came from the GQ. So again, this is students reporting. How many times were they observed and received feedback on each of these EPAs? Again, you see a difference between, this top grouping, where I'm going to go back to H&P, they were observed almost 80%, 80% of them reported being observed and receiving feedback five or more times, down to patient safety, very, very, rarely did that happen. In this third column, the schools reported how often they had more than 4 workplace-based assessments available to them when making entrustment decisions. So once again, I'm going to use the word vary, because we vary from a lot of evidence to very little evidence within this column. And the fourth column here is the percentage of students for whom an entrustment decision was able to be made. So here we see, again, variation with some of the EPAs. The groups were able to make these entrustment decisions very often, although notably not 100%. So there is not one EPA where 100% of the students were able to be to have an entrustment decision made about them, but in some much higher than others. So what this all shows you, and we're going to walk through the next slide in a moment, this is about the feasibility arm. Is this feasible? Is this doable? Do we have the evidence? Are we able to make these decisions? The second is utility. So we said before, utility is the actual ability to make that decision. So let's look at the decisions that were made. So again, same grouping of EPAs in the first column, again, not in order, and we'll come back to why. The next column tells you the percentage of students who were ready for entrustment. So, and actually this also is the percentage of students for whom a decision was made about entrustment. What percentage of them were entrusted with each of these EPAs? The difference between these two columns is that in this column, we focus on medium to high confidence in making that decision. So again, what you see here is variability. So, look towards the bottom here and, under 2% or under in these areas was the group able to make an entrustment decision with a medium to high confidence. Okay. Interesting is these last two columns. So this third column comes from the PGY1 survey. So these are the students who had been part of the pilot. They graduated to residency. They were now PGY1s. And these are the students self-reporting that they are ready in each of these EPAs for indirect supervision. And the comparison here that we're going to make is that the PDs were also sent a survey asking the same question. Do you think the, your students who are now who were part of the pilot, were they ready to perform these EPAs under indirect, without a supervisor, basically, because that's what our goal was. And even here you see, first of all, the PDs have more confidence in general than their PGY1 colleagues. So some of the students said, no, I'm not ready. And the program directors said yes, but it's not uniform there. So again, the idea is that there is some discrepancy. So I'm just going to highlight some of the differences here with one slide. There are a lot of differences that we could highlight, but here is the difference between how the students reported or their self-perception of their ability to perform these EPAs. These are the early PGY1s. And this is looking back at the entrustment group. So how often did the entrustment group say you're ready? And the gray bar underneath the 0 tells us that more often than not, the now residents, the students in the pilot program, felt more confident in their skills than the entrustment groups. So before we go to conclusions, any questions about the data? I know I walked through a lot of data here.
It just seems with those low numbers, Judy, of actual contact points. I don't know how else to call
the WBAs, you mean?
Yeah, that, how could you, something as important as informed consent, that's such an important piece of medical care. Chris, what do you, you're a surgeon, informed consent is part of your life.
Yeah, informed consent is extremely important for us. What I'm looking at is like we have proven in other aspects of the education, the students and the residents tend to be more accurate in their self-assessment compared to somebody assessing them. I think that's what I see, because they're very honest about what they think they can do, compared to somebody evaluating them.
Right. Well, that is the question: is who's more accurate here? We don't know.
Well, we do have some evidence that the students, at least at the residents, not students. I can't say students. The residents seem to be definitely on the money in terms of the accuracy of their assessment. We have through the ABS and through the American board, we have data that shows that the residents tend to be definitely very honest and more accurate in their capacity to perform a procedure or a task or patient care related.
So I think that's an interesting concept. So we did a study involving all the Northwell PGY1 interns, or PGY1 residents. So coming from, not just from our school, from all the schools and all the residency training programs. And then we also polled the program directors to see how their PGY1s were. And in the Northwell, at least, one health system, obviously, not multiple like this, the program directors rated all the students lower in most of the EPAs than the students rated themselves. So we had a different finding in our study at Northwell, and this was published a few years ago. Andrew Yad was part of the study too, as Ellen Perlman was as well. So it's interesting. And I think what Judy's saying is, what's the truth? You know, is it the program directors or is it the interns? I don't know. Why my study said different than what this study says. So the truth is somewhere in the middle, right?
So let's see what they did conclude. So we can go back to this data if anyone is interested, but I think Alice's point and everyone's point is really well taken. There's not a lot of data, and I think that that's why there's really variability in the ability to actually, come to conclusions, and goes back to like they didn't have confidence to make really high stakes decisions because of, a variety of factors, including lack of evidence. So what they did conclude, though, because this was a lot, this is a big pilot with a lot of schools, a lot of people involved, is the following, is that and let me actually go here first. So if you notice, what was found when looking at this data in this way is that clusters formed. So that, what you wanted to see was, what they were able to do is form 3 different groups, basically. And the 3 different groups included group 1, where these are 6 EPAs for which the current curriculum allows for ample assessment and the ability to draw conclusions on entrustment. So these are the ones like gather history and physical, prioritize the differential diagnosis, document the clinical encounter in the record, provide an oral presentation, form clinical questions, the evidence-based medicine, and collaborate as a member of the interprofessional team. So the idea is that these, because of the combination of data, meaning an adequate number of workplace-based assessments and confidence in making that determination, the group concluded that these are really well placed within UME. The second group is a little bit, the numbers fell a little bit, but that these 3 core EPAs, recommend and interpret common diagnostic and screening tests, enter and discuss orders, and give or receive a patient handover, that these are more squarely placed with advanced clinical experiences, like an acting internship or sub-internship, okay? But still probably appropriate for UME.
Mm-hmm.
But the third group, okay, and we can look at them quickly, are recognize your patient, or this is this was the example that Gino gave at the beginning, recognize a patient requiring urgent or emergent care, obtain informed consent, which we just heard how important that is, perform the general procedures of the physician, and identify system failures. That these are this grouping of EPAs may be more appropriate to really be able to find entrustment once the trainee, and I'm going to call this student a trainee because they continue to be a learner, but a learner on the other side of the continuum, meaning that they've already started residency. So these were if you think about it, from where we started in this pilot back in 2014, where these 13 core EPAs were defined, the idea at the onset was we should be able to do all of this at the end of medical school. But the conclusion of the pilot was not that. The conclusion was that, 3 groupings made a lot more sense because with them, they had the evidence to support these decisions. So,
I feel like I could have predicted this without doing the study, that this is the way things would have landed, that these 4 EPAs, the ones that appear to be more complex skills and more patient impacting, if they said there was entrustment and there wasn't, would have been the ones I would have predicted. I don't know. It's just, I don't want to sound like I'm a genius or, I can predict things, but That's just my thought.
Well, if you go back to the slide where we asked the program directors back in 2014, which ones did they feel confidence? It very much overlaps with this. So, but you know, we, and again, I don't want to say anything negative about this pilot. It was really important and a lot came out of it. We highlighted some of the resources, but that came out of this pilot, but it is a lot of work to get to, you know, to get to this, and this was a conclusion. But we have a few questions that we'd love to pose to the audience, just for some discussion, but we don't have to use these questions, but we thought that this was really a way that we could use the rest of our time. Any comments before we go to these?
I just have a couple of comments. I mean,
Sure.
I'm coming into this as a surgeon, so we probably may look at this a little differently. So for us, one of the things that our discussion is who initiates this information in terms of whether the resident or is it the faculty, and we feel it should come from both sides, because there was a time utilizing this system called Simple App, we wanted the residents to initiate the process. But I think it is clear that it should be a responsibility of both the faculty and the residents. The second thing, I think probably the best methodology that I could relate to is that this gives them constant, almost daily feedback. I think that that may be the importance of this EPA system, as well as it is definitely a complex process, because there's a lot of paperwork that's going to be generated, but definitely it's advantageous for the learner, because they are going to get a immediate, constant daily feedback almost.
Yep.
That's my observation.
Well, those are, thank you for sharing those observations. And does anyone want to comment on that?
So I'm going to just agree with you 100. Agree. I'm saying that. I'm just going to agree with you 100%.
I know. I thought you were going to disagree with me again.
No, Chris. No, I totally agree with you, Chris. Yes, constant formative feedback, daily basis on everything that you can is key. Yes, 100%. So this way, you know, you did this, great. This is how we get to the next level, right?
I mean, I categorize them into procedure related, especially for surgeons, and non-procedure related. I think it's easier on the procedure related, because you could say, well, you didn't tie this knot, or you didn't make the incision this way. But there are other things which are just as important, which would be patient care. How did you come to a diagnosis? How did you make the decision to operate versus observe versus what the post-op complications are? I think that I have a little bit of a struggle about how you're going to evaluate that. I think that's my observation.
And I think what this has done, it's like, you could say, why wasn't, you know, work-based assessment the standard before this? I mean, how could you not do work-based assessment and put learners with people who have real life problems, you know? Like, we should have been doing this anyway. So I think this is given a framework to help people realize that work-based assessment is what we need to be doing. Whether it has to be this complex or not will be a discussion based on resources.
So I think the problem with the work-based assessment in the past, right? And I instituted one when I was a residency director, or direct observations of students would have an attending watch them do an entire encounter with the patient and the family and the presentation and everything, is that they knew they were being watched. They performed differently than when they were not being watched, right? As opposed to a formative work-based assessment where they don't feel like, oh my God, I'm being watched, I got to do something. But the formative part, which is relatively new, is the key. Is this where, listen, I'm here to help you. You could do this a little differently. This is the way it would work better, right? As opposed to like, oh, this is my supervisors, they're grading me, they're going to send an evaluation of me, and I got to, look my best, as opposed to, do what you do and then having somebody coach you through the process with formative feedback. So I think that's where the key is the formative part of it, which is relatively new to a lot of people. It's always been high stakes.
Absolutely. Debbie has her hand up.
I just wanted to comment on the other two questions that you have here about program directors and how they, whether they would want to see this either post-match or pre-match. And I think that's an interesting question for the outputs group on curriculum renewal to look at.
That's really good.
And
idea.
try to get some feedback from our program directors about those two questions in relation to that whole process. Just, I don't have an opinion about it because I'm not a program director, but although, given some of the concerns that you expressed about, how, I guess accurate or it is, is that something that it should be part of our outputs. But yeah, I think it's a really interesting question. And great presentation. Thank you.
No, I predicted, and Gino and I had many conversations about this because we initiated a project on workplace-based assessment in the 3rd and 4th year and it is very much formatively based, as he pointed out. But I said we have to be prepared to do an APA report upon graduation. I thought that we would be there by this point in time, and we still may get there. I don't know, but I don't know. I hear reading seeing the data, seeing what actually they were able to produce is really humbling. I mean, this was an extraordinary amount of resource that was put into the system, and yet they still said we cannot make summative high stakes decisions. So that really gives me pause. I don't know what's going to happen, but I know we're almost out of time and we have one more slide that we have to get to. This is really I hope that this conversation continues because it's definitely
your last question is your most interesting though, Judy, just before we do this.
Sure.
Would PDs want to see and would they trust the decisions pre-match? Because we're in a very new era from when this study was done. I just want to point out, we no longer have step 2 CS, clinical skills.
Yep.
Step 1 is pass fail. And now the third thing is, maybe there's a fourth, but the third is interviews are virtual as of now, whether that changes. And then without all this other data, the program directors, are they scrounging to what else is there that I can grab onto on how to put these applicants on my list? So I think when this study was designed, all these changes in med-ed have happened since this study to realize that, which are very large med-ed changes. These are not small steps. I don't know. That's just my thought about it being a program director. And Gino, you've been a program director.
Yeah, no, I agree. Would I use it? Absolutely. Right? It's getting harder and harder to pick applicants, right?
Right. I mean, what do you say? There's A and there's B, and what's the difference in A and B? And I haven't even met the person, or they look like they really do on the screen. And, who are they? And all the other variables that are going into rank lists today. There's a lot of variables going into rank lists that, were not considered in the past. I mean, Chris, I don't know, were you involved in the surgery rank list or not?
Yeah, I do. I just came up with number one, what I thought would be for each program should evaluate themselves and say, what kind of program are they? Are they purely academic, purely clinical, a mixture? I think that's going to create the foundation for who you're going to recruit. One other observation, just recently having done the rank list, is that a lot of the schools are not even describing what percentage the student falls under anymore either. So it used to be one of the tools where you could say somebody who is in the 10th percentile, 5th percentile, or 25th percentile. We can't even say that anymore. A lot of schools are not describing them.
Right, they're not using that percentage.
Yeah.
We are at time, so I appreciate it. I just want to announce that there is a Survey Monkey. Wendy, maybe sometimes you put that in the chat. You will get the PowerPoint if you attended today with the Survey Monkey link again. The next one on April 11th is a representation of April is Diversity Month. And we're having a talk by Hetty Wald, who is, I would say, somewhat of an expert on bringing out the history of the Holocaust and thinking about atrocities in terms of medicine during the Holocaust and how that could, historical perspective could impact what we're doing today in terms of different things. It's definitely a heavy topic, a unique topic, for at least fits into the issue of diversity, equity, and inclusion. And that is the month April is, so I decided to put this talk on. So spread the word if interested. Thank you, Wendy, as usual. I'm going to stop the recording now.